Welcome to the deep dive. Okay, so if you've ever tried to figure out healthcare eligibility in the US, you know it's a maze, even for citizens.
Absolutely. It's complex.
But then you layer on immigration status, and oh boy, the system suddenly pivots on these really specific, kind of confusing legal terms like lawfully present versus qualified alien.
Uh-huh. Tiny differences with huge consequences.
So our goal today is really to give you that policy shortcut. We want to help you cut through the complexity. We've dug into some serious sources, think groups like the Pennsylvania Health Law Project, deep dives from the Congressional Research Service, and info from Fair Health and the Urban Institute.
Yeah, the aim is to make sense of this patchwork.
Exactly. We're going to break down how non-citizens actually access health coverage in the U.S.
And it's so important because, the numbers really tell a story. Non-citizens, they face uninsured rates almost 4 times the national average.
4 times.
Yeah, and a lot of that comes down to federal restrictions. The key thing to grasp, really, is that eligibility isn't primarily about how much money you make. It's about fitting into these very specific legal boxes, especially qualified alien and the wider lawfully present category. That's what dictates access to the big programs.
Right. And we're definitely going to unpack those rules, including some surprising workarounds like emergency medical assistance or EMA. Plus, we'll look at those real-world barriers, too, like the public charge rule concerns and, language access issues.
There's a lot to cover.
Okay, so let's dive right in with those legal definitions. They're clearly critical. Tell us about the most restrictive status, first the one needed for many big federal programs.
Right, that would be the qualified alien status. And it's not just, a general description. It's a specific legal term, mostly defined back in the '96 Welfare Reform Act.
Oh.
So if you're a lawful permanent resident that's a green card holder, you're considered a qualified alien. Same goes for refugees, asylees, and survivors of trafficking or severe domestic violence. That qualified status is kind of the main key to unlock most federal public benefits.
Got it. Qualified alien, green card holders, refugees, asylees, etc. And the other category, the broader one.
That's lawfully present. So this group includes all the qualified aliens we just mentioned, but it also brings in others. Think non-immigrant visa holders who are here legally and haven't broken the rules of their stay, like students, certain temporary workers, maybe people with humanitarian parole.
Okay, so it's a wider net.
Exactly. And the practical difference is huge. Some programs, like the Affordable Care Act Marketplace, use this lawfully present standard. But others, particularly Medicaid, usually demand that stricter qualified alien status.
All right, that distinction is clear. Qualified alien is stricter, lawfully present is broader. Now let's tackle what sounds like the biggest roadblock for many immigrants, even those who get that qualified alien status. The 5-year bar.
Ah, yes, the 5-year bar. It's a major one. So even if you get your green card, become a lawful permanent resident, a qualified alien, you're often still blocked from getting full federally funded Medicaid for 5 full years after you legally enter the U.S.
5 years.
5 years. It's a cornerstone of the federal rules that came out of those reforms in the late 90s.
So you could have permanent legal status but still be locked out of basic health coverage for half a decade. That really does sound like a trap. But you mentioned exceptions. Our sources definitely highlight some crucial ones. Who gets to skip that waiting period?
Right, the policy is riddled with exceptions, which is good, but also confusing. The 5-year bar does not apply to a few key groups. Pregnant women are exempt, children under 21 are exempt, and refugees or asylees are also exempt.
Okay, hold on. Veterans and their families too, right?
Yes, veterans and certain family members as well. Good point.
But the refugee asylee part, that feels like the bit people might stumble on. So you get a green card, you're a qualified alien, you face the bar. But a refugee who might not even have that permanent status yet gets immediate access. Why?
It really boils down to the reason they were granted status. Refugees and asylees are here because they're fleeing persecution. So policies generally recognize they need immediate help to get settled.
Ah, okay. Humanitarian grounds.
Exactly. Their eligibility for full Medicaid is immediate because of the urgent circumstances. For a typical LPR, the system assumes, a longer path to integration and eventual eligibility, but not necessarily day one access.
That makes more sense now. It's the purpose of the status driving the immediate access, not just the label itself.
Yeah.
Okay, and what about children and pregnant women? You said they're exempt too.
Yes, and they actually get arguably the best deal in terms of access rules. For kids under 21 and pregnant women, they only need to meet that broader lawfully present standard to qualify for federal Medicaid or CTRI-B.
So not even the strict qualified alien status.
Nope. They bypass the qualified alien requirement, and they bypass the 5-year bar. Basically, the system prioritizes the needs of these vulnerable groups over the stricter legal category requirements. It's a major source of confusion, but also a critical access point.
Absolutely. So the big takeaway for you listening is the system isn't uniform. Specific groups get specific pathways, sometimes bypassing rules that apply to others. Okay, let's shift to the Affordable Care Act marketplaces like healthcare.gov. If I'm lawfully present, maybe in that 5-year bar period, can I use the marketplace?
Yes. The ACA marketplace uses that lawfully present standard. If you meet that, you can enroll. But it's crucial to note, unauthorized immigrants are generally shut out. They can't enroll in the marketplace, even if they could pay the full premium themselves.
Right, no marketplace access for undocumented individuals.
Correct. But the marketplace does offer one of the most important federal workarounds, specifically for people caught by that 5-year bar.
Okay, tell us about that, because normally marketplace subsidies, the tax credits, and cost-sharing help are for people earning between, 138% and 400% of the poverty level?
Exactly. Usually, if your income is below 138% FPL, the system expects you to be on Medicaid. But what happens if you're, say, a new green card holder, lawfully present, qualified alien, income below 138% FPL? But the 5-year bar blocks you from Medicaid.
You fall right through the crack. No Medicaid, income too low for typical subsidies.
Precisely, there's a huge gap. So the ACA has a special rule. If a lawfully present immigrant is ineligible for Medicaid only because of that 5-year bar, they become eligible for the full marketplace financial help, the tax credits, the cost-sharing reductions, even with income below 138% FPL.
Wow. Okay, that's a really vital safety net built right into the ACA. It's kind of impressive to see a policy designed specifically to catch people falling through the gaps of another policy.
It is. It prevents what would otherwise be a complete coverage blackout for many newly arrived low-income LPRs.
Now, even with that fix, federal rules still leave gaps. What about states? Are they stepping in?
Yes, increasingly so. This is a major trend. Since federal rules are restrictive, quite a few states are using their own funds, state tax dollars, to cover residents who don't qualify federally. As of early 2024, the sources say 12 states plus D.C. offer state-funded coverage, often like Medicaid, to income-eligible kids regardless of immigration status.
Regardless of status. Wow.
Yes. And it's expanding to adults, too. California, Illinois, New York, Oregon, plus D.C. Again, they've extended state-funded coverage to some income-eligible adults who would otherwise be excluded federally.
That really shows a shift in priorities at the state level, doesn't it? Before we move to the ultimate safety net, just quickly Medicare. For immigrants who live here long-term, reach 65, or become disabled, how does that work?
It mainly reinforces that long-term residency idea. To get premium-free Medicare Part A and enroll in Part B, a lawful permanent resident generally needs to have lived continuously in the U.S. for 5 years right before they become eligible for Medicare.
So another 5-year requirement, basically. Essentially, yes. It shows, again, that for these big federal programs, it's often not just about having status now, but proving that consistent documented presence over time.
Okay, let's pivot completely. What if someone is not lawfully present, or they just don't meet income rules for the ACA or state plans? What's the absolute bare minimum safety net?
That really comes down to emergency medical assistance, or EMA. This is a limited form of Medicaid coverage specifically for a serious acute medical crisis. And the crucial part, eligibility doesn't depend on your immigration status.
Okay, available to everyone, but only for emergencies. What counts as an emergency?
Right. It has to be a true emergency medical condition, EMC. We're not talking about, getting a checkup for a cold. And EMC is legally defined as a condition with severe acute symptoms where, and this is key, not getting immediate medical attention could seriously jeopardize your health, cause severe problems with bodily functions, or serious dysfunction of an organ or body part.
That sounds very specific, and the examples are telling, right? Labor and delivery, automatically considered an EMC, covered. But routine prenatal care, generally not, unless it's a high-risk pregnancy that itself becomes an emergency situation. And things like planned organ transplants, definitely excluded from EMA coverage.
And getting EMA approved sounds like, a bureaucratic nightmare, especially during a crisis. The doctor's note needs specific language.
Oh, absolutely. The paperwork is critical. It's not enough for the doctor to just say the patient is very ill. The letter submitted for EMA approval has to use that precise legal language. That lack of immediate care would place the patient's health in serious jeopardy, cause serious impairment, etc.
So you're literally fighting for your life and someone's checking a form to see if the magic words serious jeopardy are there. That's something.
It is. And the documentation needs to be specific about treatment, duration usually requested for maybe up to 6 months, using calendar dates. It often needs to spell out the severe consequences if treatment isn't provided. It's a reactive system, designed for crisis, not prevention, and very tough to navigate when you're already under immense stress.
Okay, so EMA is the crisis safety net. What about just regular primary care, seeing a doctor for non-emergencies?
That's where the second huge piece of the safety net comes in. Federally qualified health centers, or FQHCs, and similar community health clinics.
Right, the community clinics.
Exactly. These places get federal funding, and part of that deal is they must serve everyone. They provide primary care, often dental, sometimes mental health services, on a sliding fee scale based on income. Your immigration status, whether you have insurance or ability to pay it, doesn't matter for accessing care there. They're absolutely vital.
And we should also quickly mention EMTALA, right? The hospital rule.
Yes, EMTALA requires nearly all hospitals with emergency departments to screen and stabilize anyone experiencing a medical emergency, regardless of their ability to pay or immigration status. Stabilization, though not necessarily ongoing free care.
Right. Stabilization isn't the same as full treatment or admission, and there are a few other public health things exempt from status checks.
Correct. Things considered critical for public health safety. Immunizations, testing, and treatment for communicable diseases, those are generally available regardless of status. And programs like the Healthy Woman Program for breast and cervical cancer screenings often fall into this category too. Public health benefit outweighs the status barrier.
Okay, that covers the main programs and safety nets. But let's talk about the hidden barriers. Because even if someone or their child is technically eligible for, say, CHIP or Medicaid, why don't they always sign up?
Yeah, this is huge. The biggest non-eligibility barrier is simply fear. Fear of interacting with government agencies, fear that seeking help might somehow lead to immigration enforcement action, and specifically, a lot of persistent fear and confusion around the public charge rule.
Public charge. That's caused so much anxiety. The idea that using benefits could hurt your chances of getting a green card or entering the country. Let's clarify that. Does using Medicaid make you a public charge?
Generally, no. Under current policy, using most health benefits like Medicaid for routine care, CHIP, ACA subsidies, that does not count against you in a public charge test.
Okay, that's critical. Most health benefits are safe. What's the exception?
The main exception is using Medicaid to pay for long-term institutional care, like staying in a nursing home indefinitely. That could potentially be considered. But regular doctor visits, prescriptions, even hospital stays covered by Medicaid, generally not an issue for public charge. And ICE policy also designates hospitals and clinics as sensitive locations, where enforcement actions are typically avoided.
That's really important information to get out there. And related to fear, what about mixed status families, say undocumented parents with U.S. citizen kids who are eligible for Medicaid or CHIP? Does the parent's status mess up the kid's application?
It absolutely should not. The system is designed so only the status of the person applying for the benefit the child, in this case, matter.
Just the beneficiary.
Exactly. If the U.S. citizen child is eligible based on income and residency, the parent's immigration status is irrelevant to that child's application. There are privacy protections in place specifically to encourage eligible people, especially children, to enroll without fear.
Okay, good. One last thing we found, kind of tangential but related to financial security, life insurance.
Yes, that came up. It's an interesting point. Even if health insurance is complex, other financial tools might be accessible. Non-citizens, even undocumented individuals who don't have a social security number, can often purchase life insurance term, whole life, etc., using an ITIN, an individual taxpayer identification number.
An ITIN, okay.
Right. It just shows that some avenues for financial planning and security exist, even outside the tangled web of health coverage eligibility.
So, wrapping this all up for you, the listener, the main takeaway really seems to be that healthcare access for immigrants in the U.S. isn't a simple yes or no. It's incredibly granular.
Very specific pathways.
Right. Access is possible, but it's through these very specific targeted routes. Maybe it's the lawfully present exemption for kids, maybe a state expansion program, maybe emergency care via EMA, or routine care at an FQHC. You really have to know the specific rule that applies to your situation.
Absolutely. And it matters beyond just the individual. There's a public health dimension here. Sources like the Congressional Research Service talk about the healthy immigrant effect. People often arrive healthier than the average U.S.-born person.
Right. I've heard that.
But over time, their health status tends to decline and match the general population's. So ensuring they have ongoing, timely access to care isn't just compassionate. It's important for overall community health outcomes. It prevents small problems from becoming big, costly emergencies down the line.
That makes perfect sense. And here's maybe a final thought, something provocative based on the economics mentioned in the sources. The CRS noted that insured immigrant groups often use less in health services, on average, than what's paid for their private coverage.
Hmm.
Yeah, so it raises this question. If these populations are sometimes actually net contributors to the insurance pool, how should policymakers weigh the upfront perceived cost of expanding access against what might be guaranteed long-term economic benefits and better public health for everyone? Something definitely worth mulling over.